Hello, everybody, and welcome to our class on anxiety, the theories and management of anxiety. So let us consider two scenarios. Let us imagine you're walking down a street and you see a snake. So what happens then is you're really fearful. You can either grab a stick and fight the snake, or you can run away from the scene as fast as possible. Consider the scene 2, where imagine you're at Goa. You're sitting calmly and peacefully. You have your legs up and you're drinking what you like and you're really relaxed. So these two scenes can represent two parts of the nervous system, the sympathetic system and the parasympathetic system. The first scenario where you saw a snake can be likened to what the sympathetic system does to you. What happens then is you tend to increase your rate of breathing, so your bronchi gets relaxed. More of your blood rushes to your muscles, and that is why you wish to run from the scene as fast as possible. There's a lot of secretion of adrenaline and noradrenaline. Your mouth goes dry and your pupils dilate. So this is what happens when you are in a state of fear or you want to run from the scene as fast as possible. And coming to the second scene where you're sitting calm and peaceful, this is similar to what the parasympathetic system does to you. You're enjoying your drink, that is why your saliva flows. And your gut is moving fine, which means the food is moving in the right directions and the food is getting digested well. And your pupils are constricted, which means you're in a state of calm. So these are the two systems I would like you to remember when we consider the phenomenon of anxiety. The American Psychological Association defines anxiety as an emotion characterized by feelings of tension, worried thoughts, physical changes like increased blood pressure. But we'll have to distinguish the experience of anxiety as a subjective emotion and an objective occurrence of some somatic changes associated with this emotion. So a patient may have anxiety, may be extremely anxious, but may not show the physical manifestations of anxiety. That is a somatic expression. But then in dissociation, the patient may have marked physical changes, and this has been seen when the patient does not complain of feeling anxious at all. So coming to what the symptoms of anxiety are, they can be broadly divided into the somatic and autonomic, and the cyclic, which is a psychological. The somatic manifestations are when the patient feels his or her heart beating very fast, a phenomenon called palpitations. The patient may have difficulty breathing. They'll have a dry mouth. They'll have a feeling of nausea and vomiting. They will want to go to the bathroom and pee. They'll have dizziness. They'll have muscle tension, sweating. They'll have knots in the abdomen, tremors, and cold skin. Coming to the psychological, the patient may feel dread and threat. The patient may be irritable. The patient may have panic. They'll have anxious anticipation. They'll be worrying over trivia. They'll have difficulty concentrating. They'll have difficulty sleeping, and they'll have inability to relax. So in psychiatric terms, we would like to distinguish between the different types of anxiety disorders itself. So the principal anxiety syndromes can be grouped according to generalized anxiety disorder, social and specific phobias, and panic disorder. So patients who suffer from generalized anxiety disorder, they experience the persistent anxiety and worry that is out of proportion to whatever is happening in front of them or whatever circumstances exist. Coming to the three-dimensional model of anxiety symptoms, that is, in this figure, you will see that it has an x-axis, a y-axis, and a z-axis. So considering what is normal for a person, moving from the x-axis towards the left side, the patient may say, I am anxious with a good cause, and it may seem normal. But on the other hand, it may be pathological when the patient feels anxious without a cause. Moving up on the y-axis, If the patient feels anxious at that particular moment, it is anxious at a particular state. When it becomes as part of a trait of a person, that is when the patient feels anxious all the time. And towards the y-axis, which is the third dimension, the anxiety may be psychological or somatic, in which psychological is when the patient feels anxious inside, and somatic is when the patient develops physical manifestation, saying my hands shake and I have palpitations, etc. So the other psychological functions are also affected during anxiety. That is, the capacity for the patient to reflect on himself is decreased, their field of consciousness is narrowed, and the patient will have instant physical action, will have the energy for instant physical action. But this works as a disadvantage when the patient plans to think about whatever he's going through, to review, and to take a variety of different factors into consideration. So the variations of activity with anxiety are seen when a patient experiences a disaster. So let's say a patient or a person is exposed to a disaster. There are some people who be numb and inert and inability to take action. And the others are tense, restless, and they constructively overactive. And there are a few others who are extremely scared and unable to do any activity at all. So moving to the recent history of anxiety, different psychiatrists in different points of time gave up different theories of anxiety. The French psychiatrist Benedict Morel in the 18th century, he argued that the anxiety was triggered by a disease in the nervous system. Maurice Krishnaba was an Hungarian ear, nose, and throat specialist, believed that the anxiety was caused by cardiovascular problems. And this could be rectified by consuming caffeine, which was later found out to be false because caffeine led to increased symptoms of anxiety. And Moritz Benedict, who was a professor in the neurology at the University of Vienna, he believed that the dizziness associated with the panic attacks was associated with the problems in the inner ear. And coming to Sigmund Freud, who was the founder of psychoanalysis, he believed that anxiety should be distinguished from other forms of nervous illnesses or neurasthenia. So this was on his paper titled "On the Grounds for Detaching a Particular Syndrome from Neurasthenia" under the description anxiety neurosis. So what happens when a patient has anxiety? Anxiety sets in a number of physiological changes, and these changes are helping us to deal with the sudden threat to our existence. So what I just explained to you before, the changes generally happen with the autonomic nervous system. And this autonomic nervous system, the function of this ANS is to oversee the physiological processes, which is the breathing, temperature regulation, and blood pressure. The Peter Lang propounded a three systems model of anxiety, in which he believed that anxiety manifests in three ways. That is, the first is what we say and how we think. So let's say we worry about a problem, then we speak about the problem and how it concerns us. The second is how we behave towards the problem. We start avoiding certain situations that puts us in the problem, and we are constantly on guard against any sort of trouble. And coming to the third is the physical changes, where the patient may have an increased heart rate, faster breathing, and the facial expression is always changed. So the Diagnostic and Statistical Manual of Mental Disorders defines anxiety as an apprehensive anticipation of future danger or misfortune, accompanied by feeling of dysphoria or somatic feelings of tension. So this danger that you anticipate, it could be either internal or external. Coming to the theories of anxiety. So there are the four theories of anxiety that have been put forward. The initial one was propounded by Freud, which was psychoanalytic. Later then came the behavioral, cognitive, and then the neurobiological. I shall speak about these theories as we keep moving along. the psychoanalytic theory of anxiety. So this was definitely founded by Freud, and he believed that it was due to a failure to deal with the invisible, unconscious, and the primary sexual psychological drives. So this was come to understand, has come to believe to be the cornerstone of psychoanalysis. And unlike the other nervous illnesses, this anxiety neurosis was caused by the failure to satisfy the buildup of sexual excitement. So he believes that there are two types of anxiety, that is the realistic anxiety and the neurotic anxiety. The realistic anxiety arose from threats in the external environment, whereas the neurotic anxiety arose from within. And we are not sure about the actual cause of it. The later theory, in his talk called Anxiety and Instinctual Life in 1932, he believed that there is a component called id, that is a wild and primitive psychic desire of instinctive desires. So the job of managing and controlling these desires belongs to another component called ego. And all of this is deep in our unconscious. So when the ego fails in the task of controlling the id, that is when the patient will develop neurotic anxiety and desire is repressed. Moving on from the psychoanalytic theory was the behavioral theory of anxiety. This was propounded by John Brodess Watson, and he was a leader of behaviorism. And this dominated much of the academics from in the 20th century. So behaviorism constituted a branch in which the few of the other researchers of Wilhelm Wundt and William James, and they rejected the psychoanalysis that was propounded by Freud. In 1920, Watson and his followers just believed that the behavior is just a simple explanation. That is, we learn a particular behavior. So they actually conducted an experiment on Albert, who was a 9 months old child, the son of a wet nurse at London's Harriet Lane Home for Invalid Children. What they decided to do is to test Albert's reactions to a wide range of objects, including a white rat, rabbit, a dog, cotton wool, and burning newspapers. So once they saw him responding to the previous mentioned objects, they showed Albert the white rat for a second time. And as soon as Albert touched the rat, the psychologist slammed a hammer against a steel bar, and this produced a sudden and frightening loud noise. Later on, over the next few weeks, they discovered that Albert was afraid of the white rat, even when the steel bar was not struck. And later, the child was scared of objects that resemble the white rat, such as the rabbit or even Watson's hat. So this is how they studied the effect of this theory, that is the behaviorism. However, the behaviorism did not provide a complete explanation of anxiety, but the contribution has been quite huge. Moving on to the third theory, in 1956, what came about was a cognitive revolution. So cognitivism was a branch which aimed to identify and understand the basic processes underlying how human beings think. This was in contrast to behaviorism, because behaviorism did not decide to study thoughts because it could not be observed directly. Now, coming to cognition, how do we understand what cognition is? So cognition is a processes by which whatever sensory input is absorbed is transformed, reduced, elaborated, stored, and recovered. So the certain terms such as sensation, perception, imagery, retention, recall, problem solving, and thinking, all of this are the hypothetical stages of cognition. Now, the cognitive theory interprets anxiety as that the senses act as an early warning system. So the sensory system picks up something important and it passes it on to the logical thinking part of our brains. So how we develop anxiety is because how we interpret a particular situation. So when we can detect a threat that we cannot handle, that is when we feel anxiety. For example, you are sleeping at night and there's nobody around and it's very quiet, and you suddenly listen to a strange noise in the night in your house or somewhere outside. So that can be a threat. Or it could be an internal threat. For example, a panic attack is said to happen when you have a tightness in your chest. Now, you may believe that this tightness in your chest is a symptom of serious illness, such as a heart attack. So this can lead to a vicious cycle in which you have physical manifestations of anxiety. And this you may believe as you have you're reaching to the point of death, which leads to more anxiety. So this is a vicious cycle. So moving on from the cognitive theories of anxiety, we come to the more recent theory, which is the neurobiological theory of anxiety. And this theory believes that we as humans are not very different from animals. We are as good as just lizards or reptiles when it comes to detecting danger and responding to danger. So in the following slides, I will discuss with you what happens to our brain when we feel anxiety. So I will have to explain to you a few areas of the brain related to anxiety. One is the limbic system. This limbic system plays a major role in the production of emotions. And this limbic system is closely similar to the first mammals that were around for 200 million years ago. And it is part of the forebrain. And its function is to make rapid and conscious appraisal of a situation in order to determine what kind of emotion or reaction is appropriate for that situation. Now, the forebrain, the anterior part of the brain, takes part in the planning, decision-making, language, and conscious thought. So it's the frontal lobes that make us constantly think and regulate emotional responses. The other organ in the brain is the hippocampus, which forms and stores memories. It converts the short-term memories to long-term memories. And the amygdala is something that is quite relevant and important. It is responsible for fear reactions in all species, including reptiles, birds, and mammals. So this houses a lot of unconscious fear memories. And this leads to us becoming anxious without even knowing why. And the amygdala is also very well connected to the other parts of the brain, such as the thalamus, which is sensory specific, the cerebral cortex, which processes the sensory inputs, the hippocampal formation, which is sensory independent, and the hypothalamus, which controls the breathing, the body temperature, and blood pressure. So this is the diagram which describes to you the forebrain, the position of the amygdala, and the medial prefrontal cortex and the ventral prefrontal cortex, and which are parts of the prefrontal cortex. So the amygdala manages to interpret a particular threatening situation very rapidly. Once it identifies it, we suddenly turn anxious and we don't realize why we feel afraid. So the amygdala designs the entire phenomenon to save our life first and then ask the questions later. Now that we have seen the different theories of anxiety, we shall move on to how we shall manage the different anxiety disorders. And in order to manage the different anxiety disorders, we will have to know what are the types of anxiety disorders. That is a panic disorder, agoraphobia, which is the fear of places, where it may be difficult or embarrassing to escape if a panic attack should occur, such as crowds in public transport or closed spaces. Generalized anxiety disorder, specific phobias, a mixed anxiety and depressive disorder, and selective mutism. That is when the patient has a failure to speak in social situations in which there is an expectation to speak. Now, coming to the flowchart of trying to figure out what kind of phobia or what kind of anxiety disorder the patient has. We would have to identify whether the patient has exaggerated autonomic arousal or the patient has a reaction to some sort of a danger that the patient perceives. And does the patient have a particular medical condition or a substance related problem? If it's no, then you will ask the patient again or try and figure out what signs or symptoms the patient has. Supposing the patient has a medical condition or related problem, you have to figure out whether that the anxiety problem is co-occurring with the medical condition. We will have to find out whether there are specific triggers causing anxiety and avoidance. If yes, then it's probably simple phobia. If the patient has recurrent panic attacks, patient is catastrophizing about anxiety and panic symptoms, then it could be a panic disorder. If a patient displays avoidance of open and crowded spaces and worries about being, about panic in public spaces, then you have to consider agoraphobia. If the patient has chronic, exaggerated, excessive, unwarranted worries and is preoccupied about the future or everyday issues with associated tension, then you have to consider generalized anxiety disorder. If a patient has preoccupation about any criticism or being judged negatively by others and avoids social gatherings, then you consider social phobia. If a patient has preoccupied with any recurrent or re-experiences a traumatic event, then you can consider post-traumatic stress disorder. If a patient has unwanted, intrusive, recurrent thoughts, images, or urges, and which causes extreme distress and discomfort, then you can consider obsessive compulsive disorder. These are the different diagnoses of anxiety disorder you have to consider before figuring out whether the patient has anxiety disorder. So moving on to assessing a patient presenting with anxiety symptoms, we will have to figure out whether if the patient really has anxiety. Is the patient apprehensive, excessively worried, very fearful inappropriately, complains of palpitations, shortness of breath, dizziness, trembling, has butterflies in the stomach? Then you consider, if patient does not have any of them, you consider other diagnoses and the appropriate referral. Then you figure out whether the patient has a very severe anxiety or not. If yes, then you manage the severe symptoms, you reassure, and you have to educate that anxiety is normal and will not harm the patient. And if it is not severe, then you have to identify whether it is an anxiety disorder and speak to the patient and ask the patient, what are the patient's symptoms and fears? What did they stop the patient doing? How long have they had the symptoms? And what led to the patient coming to the therapist now? You'll have to identify whether it meets the diagnostic criteria for panic disorder, social anxiety disorder, or generalized anxiety disorder. If not, you consider other diagnoses and appropriate referral. If yes, you use a clinical practice guidelines to plan the treatment. So like I just said, the assessment and initial management, you would have to consider whether the patient has comorbid disorders, substance use, suicidal ideation, patient has any psychosocial stressors. You start considering whether the patient can change his lifestyle, adopt a healthy eating habits, maintain a sleep hygiene and exercise, address the substance use, and provide psychoeducation. You can go ahead and wait, watch and review. Then later you will decide to plan the treatment. So this treatment should be in collaboration with the patient. You consider the severity of the symptoms, choose what kind of treatment would suit the patient, and you will have to see whether the patient has responded to a previous treatment and the availability of the particular treatment modalities when you mobilize the psychosocial supports. The initial treatment based on severity depends on whether the patient has mild, moderate, or severe. If the patient has mild, you can go ahead with cognitive behavioral therapy. If it's moderate, it is either CBT or medication or CBT plus medication. And if it's severe, then it is primarily a cognitive behavioral therapy plus medication. You will later review after the initial treatment and over the period of 4 to 6 weeks. If the patient has at least partial response, you can continue treatment and monitor and progress adverse effects. And hopefully the anxiety will reduce and the symptoms will go into remission. In case the patient has no response or deterioration even after 4 to 6 weeks, then you will have to see whether the patient is adhering to the treatment or not. You review the therapeutic engagement. You rule out medication-related effects. You review the treatment goals and expectations. You reevaluate the formulation. You reassess the comorbidities, whether the patient has depression, substance misuse, and personality difficulties. And then you can choose to modify the treatment. That is, you can augment the treatment or modify it according to the initial treatment choice. So if the patient is initially treated with digital CBT, that is not face-to-face, then you change to face-to-face CBT or medication. If the patient has already been treated with face-to-face CBT, then you can add medication. If the patient is initially treated with medication, then you can add CBT, increase the dosage of the medication, or you can both increase the dose and CBT. So once that we've dealt with the cognitive behavioral therapy and the medication, these are the few of the medications that is given to patients who have various types of anxiety disorders, such as generalized anxiety disorder, panic disorder, and social anxiety disorder. The combination of medications that can be used are antidepressants, that is SSRIs, selective serotonin reuptake inhibitor, or benzodiazepines, which are basically medicines that help you sleep. So if you look at this, the first line drugs, a few drugs that you may have heard about, that is escitalopram, sertraline, duloxetine, paroxetine, venlafaxine. And the second line drugs are some drugs that can help you sleep better, such as the benzodiazepines, the clonazepam, and other antidepressants such as imipramine and painkillers such as pregabalin and citalopram. The other alternative drugs that can be used are hydroxyzine, quetiapine, phenylazine, gabapentin, phenylazine, and pregabalin. This ends my talk on the management of anxiety and the theories of anxiety. The references that I have used for this presentation are the follows.